Welcome to the 1619 Project's panel on the historical roots of the pandemic's racial disparities. This event is sponsored by Fund 2.
Hello, I'm Robert Smith, president of the Fund 2 Foundation. Juneteenth is as much a celebration of life as it is a celebration of freedom. To African Americans, freedom is life itself, because life should be free. Life should be free of slavery, free of police violence, and free of systemic racism that has inhibited the full expression of the human spirit. From 1619 to the freedom struggle being waged in our streets today, the work to perfect this imperfect union carries on. This struggle is at the core of the Fund 2 Foundation, which we created on the belief that securing African American prosperity requires the liberation of the human spirit, a mission as urgent now as it was 401 years ago. Thank you to the 1619 Project for lifting voices unheard and championing the stories untold. May we continue to strive together for freedom and a more just future.
Welcome, everybody. It's good to be with you today. I'm Jake Silverstein. I'm the editor of the New York Times Magazine. And last summer, on the 400th anniversary of the arrival of the first enslaved Africans in the British North American colonies that would become the United States, the magazine published the 1619 Project. That project was an exploration of the many ways in which the legacy of slavery and the history of structural anti-Black racism continue to shape life in contemporary America today. And of course, those lessons are more important than ever as we sit here. So I'm honored to be able to facilitate today's conversation with three remarkable journalists who were a part of the project. For starters, Nikole Hannah-Jones, the creator of the project, is a staff writer here at the New York Times Magazine. She recently won the Pulitzer Prize for her essay in the 1619 Project on how America's founding ideals of liberty and democracy were false at the time that they were written, but have been brought closer to the truth through generations and many, many years of Black struggle. Linda Villarosa is a contributing writer for the magazine and a professor at the City College of New York, where she runs the journalism program. Linda is an expert in racial health disparities and recently wrote a cover story for us on this subject as it relates to the pandemic. For the 1619 Project, she also wrote about the legacy of false scientific ideas about Black health. Jeneen Interlandi is a staff writer at the magazine and a member of the New York Times editorial board. She's a public health expert and wrote about the impact of slavery and its vestiges on the patchwork healthcare system that we have in this country for the 1619 Project. I'm very excited that so many of you have joined us today, thousands of you. In particular, it's great to see that so many students from colleges around the country are here. A quick housekeeping note, we are definitely going to keep some time for questions at the end. You can submit them at any time during this panel using the Q&A feature in Zoom. We're gonna just get right into it because we only have an hour. And in fact, Nikole is right now in the middle of finishing an important story that will be on the cover of the next weekend's magazine, and we can't keep her away from that for too long. So let's begin. Linda, I want to start with you because I'm gonna hold up this magazine from May the 3rd, which was your cover story about racial disparities in the way that this pandemic, this COVID-19 pandemic is playing out. At the time that it was published, you centered the story that you told in Louisiana, in New Orleans. At that time, Black people made up 70% of COVID deaths in Louisiana, despite constituting just 33% of the state's population. So those numbers are from early April when the story was published. can you update us on as more data has come out, not just in Louisiana, but around the country, how has our understanding of this pandemic's racial disparity deepened, and what do we now know?
Well, thank you for that question. It's gotten more sophisticated. So at the time when I was doing my reporting, we only knew about 14 states, what was going on in 14 states. So now the national data has expanded. Now I think the latest data looks at 1.7 million cases. So what we know is Black people make up 13% of the population, but 22% of people who have COVID. So that speaks to exposure and just having the disease. The Black death rate, Blacks are much more likely to be hospitalized, and the Black death rate in the country is double the rate for whites. And then the other thing that's sad and interesting is Black people get it at younger ages. So a bulk of people get it, I think it's between 55 and 64, are more likely to die than black people than white people who are 10 years older. And then the other thing that is striking is Black people are 3 times more likely to have someone close to them die. So it's hitting us at all levels, including just the effect on our emotional health.
So much of the data that you're describing, as you say, we have a more sophisticated understanding today than even when you wrote this story, which was just a little over a month ago. But at that time, in early April, we had only just begun to get data because there had been a kind of reluctance to release racial data in the early months of the pandemic. And it was only after letters and demands from senators, from doctors, from many organizations around the country, to the CDC, HHS, to put out racial data that finally that data began to come. At the time, how did you view that reluctance from those federal agencies to release that data?
Well, at first it felt really surprising because the for disease in infectious diseases. So when you're looking for that kind of data, and it's all categorized by race, so it was so slow to come out, states and cities started putting out the data first. So it seemed odd. If the states and cities have it, why can't they aggregate it from there? So it looks like, from looking at it now, that there was some disorganization. There was confusion about how to, I guess, spin it or how to discuss it. Because even on, I think it was April 8th, when the data came out, it seemed like a very confused way, a little bit hesitant in the way it was introduced, even though we've known and expected this to happen. There was intense pressure, not just from politicians like Kamala Harris, Cory Booker, and Elizabeth Warren, but also from the American Medical Association, from the American Academy of Pediatrics, from the National Medical Association, which is the Black doctors, to say, why don't we have this data? And the most interesting letter to me, to the HHS, came from the NAACP, which had aligned itself with a couple of other medical organizations. They said, please put out the data. Do it because we need to know where to put the resources. We know this is going to disproportionately affect Black people and other people of color. Give us the data. But at the same time, they said, please be careful with it because we think that someone's going to blame us. We're going to be blamed for this epidemic. So I thought that that was interesting, that there was hesitant even on the part of the advocates and activists to release this data.
And as that data came out, I mean, Nikole, I want to ask you, the data quickly revealed something that was becoming clear, which is that the pandemic was disproportionately affecting Black Americans. And right as that became clear, and right as the data was released and could be to support that, we saw this eruption of these lockdown protests around the country. People, predominantly white people, taking to the streets to protest these lockdown orders in different states around the country, with encouragement from the president. How would you describe the dynamic that developed at that point, and how has that dynamic persisted and affected the way that the country thinks about the pandemic, and specifically the public health measures like the wearing of masks that can help slow its spread?
I mean, what we've seen happen is what a lot of people feared would happen once we had this racial data. So on the one hand, we absolutely needed the racial data so that we could know which communities were being most impacted and send the resources there. And I should just add, the feds get their data from local health departments, and there is going to be some lag. This pandemic was happening very fast, and despite what we think, you can't necessarily just get instantaneous racial data. Some The coroners weren't collecting that. Someone has to actually go through and like look at all the forms. So there was going to be a lag naturally. But I think the fear was that once this data came out, then suddenly large segments of America would stop caring if they believed that the people who were bearing the brunt of this were Black Americans. And I tweeted about this, that it's the least shocking thing is that these efforts to open the country, these protests to open the country happened within a week or two of the racial data starting to come out all over the country, showing who was dying from COVID-19. We saw the rhetoric going from, we're all in this together, we owe this to each other, we have to stay home to save each other's lives. This idea that COVID-19 was the great equalizer, that it would impact us all, that it was this unifying disease for Americans. And then once the data started coming out, we saw this, the rhetoric changed to personal responsibility. Well, Black people shouldn't be so fat. Well, Black people should take better care of themselves. Maybe Black people should wash their hands more. So all of a sudden it became about what decisions Black people have made that made them more likely to die. And that thinnest of threads that was holding Americans to each other, where we believe we should sacrifice for each other, suddenly began to disperse. I think kind of the most egregious and disturbing example was just the night before last in Montgomery, Alabama, where 90% of people who are being hospitalized for COVID-19 are Black Americans, and the Black mayor there tried to pass a mask ordinance, and it was voted down by the city council along racial lines. And the sense was, as Black people are literally testifying and pleading, please help us save our lives, you're finding, the white politicians who were saying, basically, your life is not more important than my constitutional right not to wear a mask. So I think it's been really distressing, and a lot of people had fear that we needed this data, but anyone who studies race also knew what this data was going to mean.
And do you also see the not just the data, but the whole situation that you're describing? What kind of role do you think that's played in the protest movement that has erupted in the aftermath of the killing of George Floyd? I mean, we were talking about like the way that data was interpreted and how it fueled people's behavior back in April, but what about today?
Well, I think it's hard to assess something when you're in the middle of it, but what I will say is you can't help but feel kind of the eeriness around George Floyd's words saying, "I can't breathe," and we're also in the middle of a pandemic that literally blocks people's ability to breathe. So folks were coming out because there was a sense that there's this colossal struggling that Black Americans were already undergoing, economic, the health struggles of the pandemic. And on top of that, we're still being brutalized by the police. But what I've heard from white protesters is, and other non-Black protesters, is a sense that Black people are already out here dying disproportionately from the pandemic. It would be immoral for us to just stay at home and let them be the only ones being exposed out here protesting in the streets. And so you've seen, of course, the really multiracial nature of the protesters. And I think it comes in part from an obligation on behalf of people who are not Black, not to let Black people being the only ones who are out there exposing themselves. But I also think what is so kind of depressing about this is Black people had to make a risk calculus. You're supposed to stay at home because you are the ones who are dying the most from this disease, but what is more risky? And you have to risk your life in one way to try to save your lives in the other, which is to stop police from killing you. And that's kind of where we are.
I want to take a turn to history. So much of what the 1619 Project, of course, is about is trying to kind of see history as it acts on the present. And so, Jeneen, I want to ask you, in the piece that you wrote for the 1619 Project, part of that piece was about the smallpox epidemic, a different epidemic that ravaged the South in the immediate aftermath of the Civil War and killed tens of thousands of formerly enslaved people. Just tell us a little bit about that epidemic so that we can kind of talk about it in this conversation. What happened? How did it spread? What were the racial disparities in terms of who was affected?
So Broadly speaking, you have to understand at that time, epidemics of all sorts were very, very common. So not just smallpox, but cholera, yellow fever, all kinds of other things routinely battered the northeastern, like the whole coast of the United States. Very common. And we didn't know a lot, like we didn't know what viruses or bacteria were back then, but we understood how infectious disease outbreaks happened, and we understood kind of what you had to do to prevent them. So, we knew that if people were malnourished, if they had poor sanitation, if they didn't have good protection from the elements, that they were more vulnerable to diseases. And we knew that when people got sick, you had to isolate them so that they didn't infect others. We understood kind of all of these basic epidemiological principles that we still use today. And so what happened was, in the 1860s, there was a smallpox outbreak, and it started in the Union Army. And to prevent it from decimating the Union Army, we employed all the tools that we know worked, right? We used vaccination, we isolated the sick, so they created quarantine facilities. We made sure that sanitation in the military barracks was, up to snuff. We did all of these things, and it wasn't perfect, like lots of soldiers still died, but we contained the outbreak, we stopped it from decimating the army, and life went on. When the same outbreak emerged in the community of newly emancipated 4 million formerly enslaved people, we didn't do any of those things. There was no vaccination. There was no, let's establish better sanitation in these communities. There was no let's improve their nutrition. Let's make sure that they have better protection from the elements. We didn't do any of those things. And so, big surprise, as a result, Black people died in droves from the same outbreak that we were able to contain in the military and in the white communities. And that it wasn't just smallpox that formerly enslaved people were dying from at that time. You see the same thing with cholera. You saw it with malnutrition. They were dying from all sorts of things that we knew how to prevent. We just didn't do it, basically.
And you wrote as well about the kind of ambivalent response. I mean, as you're just saying. But what were some of the public health measures that were taken, and how did they end up not? What did the government do in response to this? And you mentioned in the piece the Freedmen's Bureau Medical Division. What were some of the steps that were taken, and how did they come up short, essentially?
So what happened was, as more and more Black people started dying, and as the death rate among African Americans at that time was even more than double the rate of whites in the same communities, it was a humanitarian crisis, a massive one. And so what happened was local officials started saying, hey, we need to do something about this, went to the federal government. And there was this real ambivalence, but what they did was they established the Freedmen's Bureau Medical Division. And what the Freedmen's Bureau Medical Division was the first national health care program. And it was created to address this humanitarian crisis. But, as I say in the piece, it was plagued with ambivalence from the start. So there were these kind of dual things, right? On one hand, white lawmakers wanted the Black community healthy enough to return to the plantations, and they certainly didn't want epidemics emerging in those communities that could potentially affect white communities, but they also didn't necessarily want the Black community to be both healthy and free. So I think there was a worry that if they were healthy and free, they might upend the racial hierarchy. And they were also concerned, and these things echo down to the present day, that if you provided any type of assistance, it would breed dependence. So what they did was they created 20 or so hospitals throughout the South to address things like smallpox outbreaks. And then they completely underfunded them, understaffed them, didn't provide them any of the resources that they needed. And so what you had was this system that was basically designed to fail from the start. So it never really had a chance to succeed. And what you see is even, I think one of the things that didn't make it into the piece, but something that has stayed with me from that reporting, is the ambivalence was so profound that I think it was in North Carolina, they built a hospital that was specifically to treat the formerly enslaved as they were grappling with different ailments and stuff. And when a couple of people at that hospital, a couple of patients at that hospital tested positive for smallpox or became infected with smallpox, they were so worried about it spreading into the white community and so reluctant to provide the resources they would need to address a smallpox outbreak that they just decided to burn the hospital down. So they burned the hospital to the ground rather than treat the Black community. And so, that's how ambivalent it was.
Designed to fail, and that, as you say, is the first federal healthcare program in this country's history.
Yes.
Linda, I want to come back a little bit to the present, and just you've covered this subject of racial health disparities for years and in different contexts. 2018, you wrote an important cover story for the magazine about Black infant and maternal mortality and the shocking numbers that have actually gotten worse since the 19th century. one of the things that you have noted in all these stories, that story as well as the story that just from last month, is how these racial health disparities persist even when income, education, and insurance status is accounted for, is held constant. So can you talk about what some of the key factors are across the board that drive this disparity?
Well, there are really two major factors, and one is the communities we live in. So public health people call them the social determinants of health, but it really, to say it in a more simple way, it's looking at where the communities where we live, learn, work, play, and pray. And so across the board, Black communities lack many services, healthcare services, quality education, outdoor space, safe outdoor space, food. But the hardest one to me is healthy air and water. And so I was thinking about what Nikole said about I can't breathe. So if you're living in a community that is polluted and you have bad air quality, that confounds with COVID. So we know that air pollution makes COVID more serious, the outcome worse. So if you're already living in a place that's polluted, and Black people are 1.5 times more likely to live near the source of particulate matter, which is sooty pollution from a company or cars, then we have this intersection of these two terrible things: COVID, which affects the lungs, and the lack of clean, healthy air, which is the right to breathe is fundamental. I think when you look at these social determinants of health, looking at life expectancy is a very clear way to look at it. And some people call it where your zip code is matters. And so I was thinking about this. We went to Chicago for the 1619 project earlier this year. Nikole and I were there with some other people. And my mother said, "Oh, would you take me to the place I grew up?" Around the same time, I had read a study that said Streeterville, which is 95% white. No, it's not. It's a little less, but it's majority white. The life expectancy is 90 years old. So my mother's community, which is Inglewood, the life expectancy in this mostly Black community is 60 years old. So I said, let's go and see what it looks like. And my mom's greatest hits tour, it was the saddest thing. There was so much disinvestment. Her schools weren't there. Even the school I went to until I was 10 years old, there was a row of houses just blocked off, abandoned. Across the street from the school, ironically named Harvard Elementary School. And I just thought, this is what it means. If you want to see why there's a 30-year life expectancy gap between 9 blocks, 9 miles, only 9 miles, this is what it looks like. You can see the difference. I think the average income in my mother's old community is $19,000. In the other community, it's $167,000, but only 9 miles away. And so that is saying there's something wrong. And it's not what people are doing wrong. Why is the city of Chicago have this place that it looks almost abandoned?
This relates to the point Nikole was making earlier about, the blaming individual decision-making when social determinants are the root cause. How much is that understood in the medical community? How much you've written for us and others about the false ideas that doctors even working today have about the root causes of some of the disparities that they might be seeing in their Black patients. How well is that, or is what you're talking about right now, understood in the medical community, and how has that understanding changed over time, if at all?
Well, I would separate the medical community from the public health community. I think it's very well understood among people who study public health. It's somewhat understood in the medical community, but it's hard to, because the second point I was going to make is that there is discrimination and racism in healthcare, in the healthcare system itself, because the healthcare system is a structure of America. So it wasn't, of course, it exists there. And so, but I think when you start to talk about it, it's not about individual doctors, it's about a structure where there's just racism is built in. And in the past, there was this idea that there was something about being Black that caused some of these underlying health conditions or caused the shortened lifespan. So it was either genetic or it was something that Black people were doing wrong. I think that that idea is thought of differently now, especially in public health circles. It's not race per se, but it's racism. The experience that it has on the body, the experience that Black people take with them when they go into the healthcare system where discrimination against them exists. So rather than say race is a risk factor for some of these diseases, it's really racism.
I want to try to go with that understanding back in time a little bit to the era of the 1860s, and Nikole, ask you about the time period in which Jeneen's piece takes place during the smallpox epidemic, and the social determinants of health, as Linda put it, that we're talking about today. There were social determinants of health as well back then, to be sure, and certainly they played a role in the profound disparities that we saw in that pandemic. Can you talk a little bit about what the social determinants of health, broadly speaking, were at that time, and how what Linda's referring to are essentially the legacies of those social determinants?
I mean, yeah. So we tend to think about the end of slavery as if Abraham Lincoln freed the slaves, and then Black people just were able to go into America and live their lives like white Americans. What we don't talk about is what liberation meant. Liberation meant overnight, you no longer had a house, you no longer had a job, you had no food source, you couldn't clothe your children. And so you saw at the end of slavery, this 4 million people who enter freedom completely and utterly destitute. And they are going into a country where they are being forced back into working on the plantations. They have clearly no access to healthcare, no access to doctor. You're seeing mass starvations. You're seeing people trying to find shelter in old burnt out buildings and churches because there's nothing. We provided nothing for people who had just gained their freedom. And that is just an environment that is ripe for lowered immune systems, for exposure to disease, for malnutrition. But then on top of that, these Black Americans are facing racial terrorism, and that produces toxic levels of stress. We all as Americans know that stress kills. Stress weakens the heart, stress weakens the immune system. So imagine the type of kind of continual generational stress that Black Americans face. One thing, when Linda was talking about how Black people are getting COVID and dying from COVID at younger ages, that's because Black Americans experience what is called weathering. And weathering means that Black people age at a faster rate than other Americans and get diseases that you tend not to see in younger people at a much earlier age because of the kind of constant stress of being Black in this country, of not just being exposed to environmental toxins, but also just the condition of how stress kind of presents in the body. And that's why Black people were dying much earlier than other places. So those conditions of, we know Black people have, $10 of wealth for every $100 that white Americans have, that Black people, regardless of income, live in the highest neighborhoods of concentrated poverty, that regardless of income, live in the neighborhoods that are exposed to the most toxics, that have food deserts, that have the least access to employment. So all of those conditions have made Black people, even today, more likely to be sick, to have to deal with the effects of toxic stress. And so we're seeing that not just in COVID, but in the way that Black lives are regularly cut short as it is. In Linda's example of Chicago is, like New York, one of the most unequal countries or cities in America. It is top 3 most segregated, racially segregated cities in America. And that is taking Black people's lives every day.
And in you both in the present and in the past, in the history that we're talking about, so often there's a failure to recognize the root causes, as we're talking about the determinants of these disparities. And I'm reminded of a great quote that you included in your piece, Jeneen, from Rebecca Lee Crumpler, who was the nation's first Black female doctor. She wrote a book in 1883 in which she wrote, "They seem to forget there is a cause for every ailment, and that it may be in their power to remove it." And we don't have enough time to tell Rebecca Lee Crumpler's whole story. She's a fascinating woman, but just briefly, who who was Rebecca Lee Crumpler, and what does that quote refer to specifically?
Sure. So Rebecca Lee Crumpler was a total hero. She was the nation's first Black female doctor, and she became a doctor at a time when it was exceedingly rare for any woman to become a doctor. I think it was in the 1880s that she got her MD. And one of the things that's really extraordinary about her very quickly is she was born free and raised in the North and became a doctor and practiced up there. But after the Civil War, you know, it's a complete mess. There's this humanitarian disaster. It's a really dangerous place for Black people free or recently emancipated. And she made the decision to actually go down to Virginia, and she took a job with the Freedmen's Bureau. And so she was one of the forces kind of working against all of this. And the book, the thing that's amazing about that book is she wrote it kind of as this rejoinder. So as Black people were dying in droves and dying in these really high rates from all of these really preventable things, this theory kind of emerged to justify it, and it was called the extinction theory. And the argument went that Black people were going extinct. They weren't dying because white people weren't doing the things they needed to do to take care of their brethren. They were dying because they were biologically inferior, and so that this was just nature taking its course. And so to try to intervene with any type of social policy to stave off this disaster would be to just kind of delay the inevitable. And this extinction theory was actually so widely accepted that US representatives openly debated it in the halls of Congress. This was not like a taboo thing to suggest by any stretch. And so when she wrote that, she was writing it to, you know, like that's kind of directed at people that were making these arguments. But the other thing is that book was not addressed to those congressmen and to those people that were making those arguments. It was addressed to Black women, to Black mothers, and to Black families. And so if you look at the book, one of the things that's really moving about it is what she's doing is she's talking directly to the Black community who's hearing all these things about extinction and doesn't necessarily know what to make of it. And what she's saying is, you're not inferior, you're not going extinct, don't listen to any of that garbage. And then the rest of the book is basically, here is what you need to know and what you need to understand to kind of survive and to fight against this. And so, yeah, that was her message.
She really was a hero. And Nikole, I want to ask you, like, kind of building on what Jeneen was just telling us about Crumpler. Well, one of the reasons that when you were coming up with all the ideas for the 1619 Project, I remember you wanting somebody to write about this question of our healthcare system today. And this takes us a little bit away from the question of health disparities in public health, but it's obviously very closely related. The Freedmen's Bureau Medical Division, as we talked about earlier, the nation's first federal healthcare program, and people like Crumpler were among the first advocates for there to be a federal healthcare program of any kind. You know, you wrote so brilliantly in the essay that was the kind of centerpiece of the 1619 Project, and which won the Pulitzer Prize very recently, about how so many advances in freedom and equality in this country, and there's, you know, examples in almost every decade since the 19th century, have come as a result of Black struggle and activism. So can you talk a little bit about the role that Black struggle and activism played in the advances that have happened in our healthcare system? I'm thinking of things like Medicare and Medicaid, but also how the role that racism has played in our failure for those advances to end up extending universally to all people with coverage for all people.
Okay, so I don't have a great deal of expertise in Medicare or Medicaid, so I'm gonna kind of stick in my wheelhouse. But the reason when I first talked to you about this essay was, of course, I wanted to talk about why we are the only Western industrialized country without universal health care. And really hoping, you know, so much about what makes us unique in America, when we look at the countries we love to compare ourselves, can be linked back to slavery and anti-Black racism. And clearly the argument is that universal health care is one of those things that every other country that we compare ourselves to believes that you should take care of your citizens, that there's a base level of humanity and services that all citizens should be provided, and we don't do that. So we look at where did we expand Medicare in this country, and we didn't expand in the former Confederate states, and we didn't expand there because white Americans have long been willing to make a trade-off that they'll hurt a significant number of white Americans if they can keep larger numbers of Black Americans from receiving some assistance that we don't believe. But I think it's so revelatory in what Jeneen said, is this sense that right out of slavery, that if you help people who have not been able to earn $1 for 250 years, if you provide any assistance to them, you are making them dependent, right? And this idea that helping Black people who have been generationally prevented from acquiring wealth, from acquiring higher incomes, will make them dependent is what we still see in conversations around whether we should have universal health care or not. That these people will be receiving something that they don't deserve, and that will make them dependent on the government. So we're still struggling with that same concept. On the other hand, Black Americans who have been generationally deprived have a strong and abiding faith that it is our duty to help our fellow Americans who have less. And so Black Americans have the highest levels of support for universal programs like universal health care, like a livable wage, that sort of thing. So I wanted her essay to really show that our inability to get over our racism hurts all of us. All of us are sicker. There are millions of white Americans who can't go to the doctor and get health care when they need it because we can't get over our racism, and that you've never been able in this country to contain the harm just to those who were intended to be harmed. Jeneen's story about the smallpox, right? So you're not treating Black people, but believe it or not, Black and white people interact, and not helping Black people get health care means that white Americans were also suffering. Unfortunately, oftentimes the only time we are willing to expand our services to help Black folks is if enough white people are hurt by something. But at the same time, we still have refused to do that when it comes to healthcare. And I was hoping that we could help Americans to think about how illogical that is and how mean-spirited it is not to want to help Americans because the most generationally disadvantaged might get something that we think is undeserving.
Linda,
didn't answer your question, but
no, well, Linda, Nikole mentioned the Medicaid expansion, and I'm curious, when we're talking about the states that refused the Medicaid expansion under Obamacare, over the last decade or so, how do we have information yet about how those states are faring in terms of the racial disparities of the pandemic, which is to say, like, how did that refusal, how is that translated into whether or not certain states are more vulnerable to this outbreak right now than they might have been?
Well, 14 states have not expanded Medicaid. And if you look at them, the bulk of them are in the Deep South. So those are also the poorest states. So the combination of poverty plus a lack of health care because they didn't expand Medicaid. And so that leaves people without health care coverage and but these are also in places where health care in general is lacking. So that combination makes, when a deadly pandemic comes in the middle, just is a recipe for disaster. I also was thinking about that today because I was reading a story in our own newspaper about states where the numbers are going up. So two of them mentioned were Florida and Texas. And those are two states that did not expand Medicaid. So as in those states, that's going to just be another recipe for disaster because it leaves people without the tools that they need to stay healthy.
I mean, it should be pointed out though, like those Deep South states are the poorest states for a reason, right? These are states that have the largest Black population. The Deep South states have Black populations that are close to half to a third of their population and have consistently, generationally passed regressive policies that have helped keep that population impoverished. They have the least investment in public institutions in general. So they were the least suited to even deal with a pandemic like this in the first place. And they have a deeply impoverished population because of the racial history of those places.
Linda, I want to, we're going to wrap up in just a couple questions and we have some nice questions good questions from the audience. You wrote at the end of your story just a month and a half ago for the magazine about how the pandemic has, among other things, been a kind of clarifying moment, right? It's rendered visible so many of the country's underlying racial health disparities, if we're willing to see them. And at the very end of the piece, you have a quote from a doctor, a cardiologist at Northwestern, who says, describing the pandemic, he says, "We get it and we see it." And so as a final question to you, I guess I want to know, now that we do see it, what is next? How do we begin to tackle these systemic issues?
Well, the first part is something we were talking about earlier. You know, racial health and wealth go hand in hand often. And so if communities, Black communities, have been disinvested in, in our communities, we don't have quality healthcare, education, jobs, clean air and water. The first thing, the most fundamental thing, is to come to grips with that and change it, because that is what is making people ill, and especially the toxic stress that Nikole talked about. That is making people ill. It's making Black people ill, and it's aging us prematurely. But also, I think there's been a much more conversation, even before now, but especially now, within the public health circles and within the medical community in general, that there needs to be a change. And there needs to be a change beginning in medical school. There needs to be a change within hospital systems. I'm seeing many more both organizations, facilities, even states demand that doctors and other healthcare providers have to go through implicit bias training or anti-racism training in order to, in California, to work with pregnant women or deliver babies. So I think, you know, one thing is a huge systemic change to our society, but another thing is in the healthcare system, where I think there's a little bit more openness to that, to say, we want to do better. We went into this profession to do no harm, and if we're doing harm, we don't want to. And so I do see that as a hopeful light.
Nikole, I want to give you the same question to end with. I know that you don't always see things in a hopeful light because you're such a student of history, but what do you think can be done to begin to tackle these systemic issues?
Yeah, excuse my daughter running through the frame, but I mean, hope is one thing, but we know what the solutions are, right? So just as Linda said, you would need the type of targeted investment into under-resourced communities. So all of that effort that went to deprive these communities, you need an equal counter effort to actually invest and fortify these communities. Clearly, we could pass universal health care immediately, and just by making sure that every American can get preventative care and get access to healthcare and not have to wait until they're so sick they go to the emergency room, that would have a transformative effect. We need to ensure that our poorest communities and Black and brown communities actually have access to level 1 trauma centers, that they have access to doctors in their communities. We know that so many Black communities, they have to travel long distances to even get access to healthcare providers. And then, you know, I think the harder issue is, how do you deal with doctors who don't believe Black people when they present with illness, who send Black people home without giving them tests, which research shows happens systemically. Black people are less likely to be believed. They're less likely to be given follow-up care. They're less likely to be given pain medicine. This leads to bad health outcomes as well. And I'm not sure how you change that. I don't know that implicit bias training can undo a system that just does not value Black lives the same. But certainly, I guess at least confronting doctors with those facts and saying this does happen is a start.
That actually is a segue to a question from a viewer. And even though, Linda, you've spoken about this a little bit already, I just want to maybe turn this question back to you, since it's something you've studied so much. This is a question from a viewer named Annie. Annie asks, as a student nurse in pursuit of a BSN, almost every disease process we are taught disproportionately affects African Americans, from diabetes, hypertension, kidney, and cardiovascular disease. We learn this fact, but it is never implied why this is an accepted reality. What can be done to teach healthcare professionals the insidious nature of this health disparity against African Americans and why it occurs?
Well, I think that if you look at it through a public health lens, and that is, you know, just the best way, is to say, yes, these are not things that Black people are doing wrong. This is not genetics. that has been disproved. So if you let that go, and sometimes that still is taught in current medical practice. I got a letter from a doctor today that was telling me about how I was wrong and their genetics are connected to all these underlying health conditions that I wrote about. He said, "You are wrong." And I thought, "You are wrong," because this is not true. It's been proven already. And so I think it has to do with, at the beginning is medical education. So in nursing schools and medical schools, there needs to be a lens that talks about the social determinants of health. And certainly social determinants of health is a super wonky way to say it, but it really is. It's like, if something is wrong with Black communities, not our own fault, but because of a history of disinvestment, of redlining, of racism, we've got to confront that and understand the intersection to health and to disease and to dying young.
I think this is why, like, the work that Jeneen and Linda did for this project is so important, because I don't think there's a ton of people anymore who thinks Black people are genetically inferior, but it is pretty common to think that there's a cultural issue with Black people, and that Black people are just simply doing things that make themselves more sick, that they are making bad choices. And that's where, when we look at how doctors don't give follow-up tests to Black people, it's because they believe Black people aren't going to actually follow up and take care of themselves, so why waste their time? That's what we really have to get to. And if people can understand the architecture that created this, as Jeneen said, that there is a cause to these health disparities, and it's not just that Black people like dying early, then if we understand what created it, then I think you can get doctors to see, okay, this is not something cultural that Black people are doing, that we should be treating Black people the same because Black people are experiencing obstacles that other people don't get.
It was even suggested initially in the early days of the pandemic by the Surgeon General.
Yes.
This is
he said Black people need to stop doing drugs, which I wasn't quite clear what that had to do with the pandemic, but there you go.
This is a question from Michael. Michael asks, there has been a lot of lip service by politicians saying that more will be done for the Black community to help them through this pandemic since they were disproportionately affected. Has anything really been done, though? I guess that's a question about whether Congress has taken any action or city councils. I mean, honestly, to the point that Nikole made earlier, sometimes the opposite is happening.
Yeah, I feel like that's a rhetorical
Montgomery
question.
City Council.
Yeah.
It's got to be a rhetorical question. No, I mean. No.
What are some ways that non-Black communities perpetuate these inequities, explicitly or implicitly, and what can we do to push change aside from the fight for universal health care? I think the second part of that question about what can be done to push change aside from the fight for universal healthcare was actually pretty amply answered by what Linda and Nikole were saying initially at the end of our conversation. But it's obviously a very important question. I know this is a subject that you care a lot about, Nikole. Somebody asks with no name attached, it would be great to hear the thoughts on the global nature of protests with Black minority groups facing the same issues around the world. In Brazil in particular, the violence against Black communities in the favelas and impacts of COVID seem like a parallel experience to that of the United States.
Yeah, absolutely. Though in Brazil, Black people are not the minority. Black people are actually the majority. They just don't have the power to run the country. But what we're seeing in Brazil is, very similar to what we're seeing in the United States. You basically have a nationalist president who doesn't necessarily believe in science, who didn't take the proper steps to try to contain the virus, and basically a lack of caring about what has happened because it is large numbers of the most marginalized people in Brazil who are also dying. I think when you look at the protests against police violence have been in every type of country, Turkey, Kenya, you've seen them in European countries. It really speaks to the way that anti-Black racism was exported by European colonial powers all across the country, and that marginalized people all across the world really relate to the Black freedom struggle. I talk a lot about how Black American struggle has helped perfect our democracy, but it has also been a beacon for oppressed people all across the world to see a racial minority that was enslaved in a majority white country that has constantly put our bodies on the line generationally to try to put forth not just the rights of Black Americans, but universal rights for all marginalized people.
And we don't, looks like we are, oh, okay, here's a question. Because of the unacknowledged presence of racism in individual doctors, both Black and white alike, how does one confront these issues with a particular physician? That's a subject that has come up in some of the stuff that you've done, Linda, writing about the specific individual personal relationship between a patient and a doctor. For instance, in the context of prenatal care in your maternal mortality story, and questions about whether doctors believe what their Black patients are telling them. Have, in that reporting that you've done and the studying that you've done of that subject, have you come across sort of tactics for handling those situations? It seems like that's what the question is about.
Well, I can speak from a personal level. I'm often the person in my family and my friends group who goes to the doctor with someone, because I'm that person. People are like, who is that? And it's like, hey, I'm that person's sister. It's not your business. I am the person that's speaking for the person, because when you are being sick is scary. Being in the healthcare system is scary, especially, we know that this discrimination exists. We hope it's not from the individual doctor we're talking to or the individual healthcare provider. So from a personal standpoint, I would say just know everything you can. Be unafraid to push back a little or to ask for more time. Just the kind of, you should be, healthcare should be dignified. You should be getting what you need from your, this is a service provider. And so I would say you have to push back. I would say take someone with you. I'm often someone's wife. Like, who is that woman? Oh, that's my wife. Clearly, I'm not the person's wife, but I'm the person doing the talking, because whoever it is frightened. My loved one is frightened. My loved one doesn't have as much information as I do. Or my loved one may be afraid. Most doctors are white. Most doctors are wealthier, than average human being, and so may not relate to the patients. So that's what I do. I also am writing a lot right now. I'm writing in my book about community health workers. In our country, community health workers have like 1 million names per patient navigator, doula, patient advocate, or whatever. In other countries, it's that they are part of our healthcare system. In our country, there's the assumption that our clinical care and our technological care is so wonderful, you don't need the human touch. And so in other countries, there's a bond. There's the like I am, my bond between the patient and the technology and the clinician. And so that in other countries is a given. In our country, it's sort of haphazard, but it does exist. And I would say that is a small solution and a kind of inexpensive, gives a job to people. It's a very caring part, is linking healthcare to a person.
It looks like we are just about at time, and I don't see any more questions. If one pops in while I'm speaking right now, I'll ask it. But otherwise, I want to thank the three of you so much for your comments, your commentary today, but also your incredible work, not just in the 1619 Project, but across the whole New York Times and in the New York Times Magazine as well. It's been so educational, informative, and in some cases transformative for so many readers. So thank you to the three of you. To the audience, thank you for joining us. And if you want to go back and watch this or share it with anyone, you can find a recording of this whole conversation on the New York Times Events YouTube channel. So thank you again. And now I guess we can go back to work.
Thank you.
Thank you.